Hello, everybody, and welcome to the Fulbright Speaker Series. I am Ángeles Vaquerizo, a Fulbright alumni from Spain living in California and a board member of the San Diego chapter of the Fulbright Association. I'm a transplant surgeon at Scripps Green Hospital in San Diego and the CEO and founder of MedApps AB, and I'm going to be your host today. Before we start, let me let you know a few housekeeping issues. The webinar will be recorded and available in a few days, and you are muted, but you can use the Q&A feature to ask questions that we will answer at the end of the presentation. We are going through very challenging times. While the COVID-19 pandemic is a global tragedy, it has also forced an acceleration of science and emerging digital health. Technology is evolving faster than ever and is currently transforming healthcare at an unprecedented rate. Our Fulbright Speaker Series brings a great opportunity to learn from the world-renowned Professor Shafi Ahmed, who will be discussing emerging technologies on digital health. Professor Ahmed is a multi-award-winning cancer surgeon working at the Royal London Hospital in the United Kingdom. He's a member of the UK National Health System Assembly, advisor to the Abu Dhabi government for digital transformation of health and innovation, ambassador for Vodafone for 5G and connected healthcare for 2020. He's a faculty at Imperial College, Barts Medical School, Queen Mary University, Bradford University, Harvard Medical School, and Singularity University, where he teaches on innovation and digital transformation. He has set up surgical education programs in over 20 countries, including conflict zones. In 2016, he performed the first virtual reality surgical operation, which was watched in 140 countries. Co-founder of Medical Realities, a virtual reality education company, co-founder of the Giant Health Summit in London, chair of the Webit Health Summit in Spain, TED, an international speaker, and one of the top 20 global influencers in digital health. Professor Ahmed's vision is to merge the world of medicine, global education, and virtual reality. I could spend the whole hour presenting his very impressive list of accomplishments, but we can wait to hear from him. Without further ado, let me introduce you to Professor Ahmed. Shafi, we are delighted to have you with us today. Thanks for joining us. The virtual stage is all yours.
Thank you, Ángeles, and what a pleasure and honor it is to be able to talk to such a distinguished guests of the Fulbright Scholar Series. Thank you so much for the invitation. So look, I'm going to share my screen and then hopefully things will work in terms of technology. Let me share my screen, make sure that's all working, and hopefully you'll be able to see this if everything's working. Okay, so let me take you on a journey what I call in terms of the digital future of health. It's not the future of digital health, that's different. It's the digital future of health, slight difference in where we are today. And Ángeles has quite rightly set out the scene of where we are today during the pandemic, and things are changing rapidly. And now we're really going to think about how we utilize that kind of this world that we live in, which is now engaged in innovation going forward. What I'm going to do first of all is just share a small video that we created with actually one of the largest insurance providers in America called Anthem. And this is just a small glimpse of the future we're talking about. last quote, as you may have gathered, was by Abraham Lincoln, who says to think about the future, the best way to think about the future is to create it yourself. And this is really an important, of course, quote around the fact that we, as individuals, as society, as healthcare professionals, need to rethink and reimagine what's possible in the future. So one of the things we talk about is this concept of the fourth industrial revolution that came out 5 years ago by the World Economic Forum. And Klaus Schwab, who was the chairman, came out with a statement back in 2015. 5 years later on, actually, we're now looking at a world where we have a convergence of technologies. One of the things we've noticed, of course, that this is really the most amazing time to be alive in medicine. Not 5 years ago, 10 years ago, but today. Imagine the riches we have in terms of technology innovation, all impacting at the same point of humanity. It's an inflection point, there's no question. Whether talk about genomics or artificial intelligence, 5G, immersive technology, wearables, 3D printing, quantum computer coming in soon, we're looking at this whole convergence. So what I want you to go away is not think about one technology, it's everything. How are we going to combine these to try to change the rationale for healthcare to improve outcomes for people around the world? And so this is the concept. We talked about the fourth industrial revolution. We're now talking about globalization 4.0. So how do we take those technologies and innovation? How do we make the world a better place? And actually, globalization 4.0 is a current terminology about a year ago coined again at the World Economic Forum, again by Klaus Schwab. We moved the needle forward around how we improve society together. The other thing I need to tell you about is how to change your mindset and become exponential thinkers. This is, of course, these exponential growth we're seeing, the rapid part of the curve we're now in. We're now seeing rapid use of innovation in all walks of life. So we have to embrace ourselves. So I want you to go away after this talk and become an exponential thinker, not a linear thinker. Our brains work in linear steps. We think about, one step after the other, that's measurable, that's equidistant. But actually, we need to change that. If I said to you, the audience, let's take 30 linear steps together, we'd all walk about 30 steps, about 30 yards or so. We all know that our minds are configured around that, our brains are configured and wired along those lines. If I said to you, now let's take 30 exponential steps together, the way that we're driving change, how far do you think we'd get? Well, let me tell you, we'd have gone around the planet over 26 times. That's the pace of change around us. And we all need to think about how that will impact all of us in terms of healthcare and how we individually understand this process. So when you go away at the end of this talk and after the Q&A, please, I want you to go away and say, I am an exponential thinker. I'm going to change the world and do things differently and challenge what's around me. We're also into education. I do a lot of education around the world, and I teach medical students, surgical trainees, and healthcare professionals globally. The other terminology I want you to come to terms with is this whole concept of education 4.0.
I remember the teacher talked and we listened. We had to memorize quite a lot too. A lot of time was spent giving out books and collecting them up again. We were sitting in rows in desks so we could see the board better because talk and chalk was the way.
There must be an industrial revolution in education, in which educational science and the ingenuity of educational technology combine to modernize the grossly inefficient and clumsy procedures of conventional education. Sidney L. Presse, 1924.
These young people are studying in a new way.
A computing calculator designed for use in high school classrooms has created tremendous excitement among educators.
The tool which has made this possible is the high-speed digital computer operating with electronic precision on great quantities of information.
If we think about the third industrial revolution, that was PCs and the internet, and we just about caught up with that. The fourth industrial revolution is what becomes possible from those technologies.
Industry 4.0 is the next big shift in the way that manufacturing operates. Digital know-how is going to be hugely important, and then people will need to be flexible because the world will change.
The future workplace and future societies, we're still moulding them as we go, and technology is one of the main pillars in what is shaping what the future will look like.
the pace of change is remarkable, with the introduction of these exponential technologies creating a paradigm shift to create Education 4.0.
So that's important. We've seen now in the last 9 months, we've been teaching remotely with, say, for example, our medical students. We haven't been as face-to-face. We're now here on Zoom sharing knowledge on a wider scale. So we're now embracing this area of the fourth industrial revolution, globalization 4.0, and now education 4.0. That's to put into context of where we were and where we've come to. But of course, fundamentally, we're trying to make change on a global level. So here's some statistics for you to kind of ponder over the next hour or so. This is the stats from the World Health Organization planning workforce resources for 2030. And they estimated we'll be about 14.5 million health workers short. That's a huge amount to make healthcare equitable. So we're going to have a huge problem on our hands about training the right personnel over the next 10 years or so. On the other hand, of course, healthcare costs are rising. We can't get away from it. The GDP of every country is going up. Of course, the US is quite high, and all of us were seeing the increase in GDP spent on healthcare because we've got an aging population generally. We also have a bigger population to deal with. And of course, there's less resource overall, and there's more chronic diseases that we're managing long term. And chronic disease takes 80% of the budget of a healthcare system. So on the one hand, we've got fewer staff going forward, and we've got rising costs. So we have to reimagine what that healthcare looks like to almost be smarter, to create a healthcare system that is affordable, that makes more sense. And that means really radically changing the way we deliver some of these ideas. And digital is one part of that solution, of course. Here's WHO recommendation over a year ago saying that we're going to require these digital interventions going forward. And they nominated 10 areas that they thought they could implement digital change to impact global health. I suspect they're going to revisit this very quickly, add many more after the pandemic. And of course, this is all about the 17 Sustainable Development Goals, and health, of course, is one of those, crucially, importantly, as part of those goals. The 9 months we've had have been difficult, of course, for all of us with morbidity, mortality. We've experienced people around us suffering due to the COVID-19 pandemic. At the same time, it's been an opportunity. What it's shown us is that we can be quick, we can be fast, we can be innovative in healthcare, we can translate ideas into clinical practice. What we've seen over the last 9 months is what I call the compression of time. This is a picture from Final Fantasy IV saying what would happen if time gets compressed. Well, actually, we have the answer. We've seen in the last 9 months, huge innovation taking place. People think differently. Their mindsets have shifted enormously. So I think this compression allows us now to get to that new normal. We're now springboarding into the future. We're catapulting from a different level. The door is open for all of us to think about health and innovation. We've seen great examples. We know, of course, recently, just today, the UK has announced that we're going to, they've passed, the MHRA has certified the vaccine from BioNTech and Pfizer, and within a few hours, it'll be coming to UK doorsteps. By next week, we'll be vaccinating high-risk groups and, of course, also people at the front line. This has come at 9 months. Remember, vaccines have taken 10 years sometimes to get to marketplace. How have we changed that? How, the word is collaboration. We've collaborated with WHO, using 172 countries, creating candidate vaccines, engaging on global facilities called COVAX. We've seen Moderna, we've seen the Oxford Vaccine Group, Pfizer and BioNTech work rapidly, change regulations. And how fast have we accomplished that? Our minds have changed and shifted. We've seen how we can innovate quickly to save mankind almost. It's been that kind of pressurized situation for all of us. Partnerships are important. Collaboration is the key word. When you go away, it's about collaboration. You can't do it on your own. Everyone has unique skill sets, and bring them together. And this is where I've seen change. We've seen, for example, CPAP machines being re-engineered by McLaren, the group that builds racing cars and other technologies, and University College London, as collaboration will create a non-patented version of a CPAP very quickly, ventilators. We've seen how we quickly build hospitals that are completely connected with infrastructure that's digital. The Nightingale Hospital in London, I was part of the leadership team, was built within 3 to 5 weeks with full integration, with 4,000 beds. Okay, we didn't use those 4,000 beds. We only used about 39 in total, but it was there as a resource, showing how quickly we can use our experiences and technology to run something efficiently. A few examples what other countries have done. I travel a lot. I've been to about 30 countries over the last 3 years, as Angeles would tell you through my social media kind of postings. It really is to figure out how other countries behave, working with governments, colleges, universities, and other institutions to reimagine this concept of healthcare. Let's take an example of Abu Dhabi, where I happen to be an advisor to the government on innovation and digital transformation. We're setting up a health summit there, an academy of learning for all the staff members. What they've done, of course, a small country of about 2.5 million people, is actually connect their healthcare system immediately. They've got central healthcare information exchange. They've now got this connected healthcare system of all 50 hospitals. Over the next few months, it'll all be connected. So you can now have a dashboard showing where this is going forward, where's the flow of patients, what the problems are, what the blockages are. How do we make healthcare better? By having rich data that's connected through a central exchange and having a central electronic health record. So these countries can do this because they're small, they're nimble, they have money, but they are thinking differently around healthcare. How about this? They've now actually opened up a university for artificial intelligence. If that's what we're heading towards, we need to create the workforce or the knowledge base around that. So they've created the first university in the world just centered around AI, and that's opening next year. Can you imagine that as we go forward? So these are what other countries are doing. They're thinking differently, and it's really important for you to get out and see the world and see where those pockets of innovation are, what can you bring back, what can you actually send out and share experiences. The pandemic has told us we're really it's a global pandemic requiring global solutions. Therefore, we all have, as citizens of the world, a responsibility to improve the lives of many. This is the health and care system of the future. Health and care are put separately because care, we don't take it seriously. Care has been completely dismissed almost from many governments around the world because it doesn't matter, but it impacts on health and costs, of course. We're going to be digital, there's no question. We're going to be connected. It's going to be data-driven, so therefore more precise. We'll be integrated, and of course, we're multidisciplinary. As we've seen recently, people change their work in terms of their work and change a different part of work and working together collaboratively, creating digital transformation. This is work I do with Vodafone, looking at what would that look like? What does the future hospital look like? Do we aim big, or do we actually make it smaller? What we need is a seamless system from the care system, primary care, and also social care, and also secondary care, and perhaps tertiary care. Seamless, all connected with a single health record, data-driven through all of this, so we can actually get more power behind our ideas that's more sophisticated in its approach. So the hospital itself could be small in the future. We think about big, flashy hospitals. Actually, we need to reduce the bed space, keep people out of hospital, prevent the illness, maintain well-being. And maybe the model is completely wrong. We should think about much smaller and more concentrated hospitals. We've seen the outpatients change. Before, we were face-to-face with clinics overcrowded. They're not going to be necessary anymore. We're now going to telemedicine. And of course, we look at the next system around the actual hospital itself. It's going to have better user interface, better user experiences. We'll think about how to manage those people, that smaller number, in a different, more efficient way to have the least amount of time in the hospital as possible. They're going to be connected through their smartphones, of course. There'll be information exchange. In the NHS here, we have an NHS app, which connects all of our data to the NHS. We can actually download data as we speak from our primary care position. Also, we move to the care in the community. We have wearables, we have sensors, we have monitoring devices, we have telemedicine platforms. We're going to really change the way people interact with their healthcare workers and the doctors. It'll be more convenient, it'll be more immediate going forward, which will make sense. We've always been hierarchical. You come to hospital, here's the appointment, you have to travel, spend a lot of time, take a half day of work, maybe a whole day off work because of the appointment. That's not what we need. We need a much more nimble, flexible approach to managing patients in the future. If we look at that and look at the patient experience being the center core of all of our work, we're going to have to change the way we behave. We're going to have to spend more time preventing illness, change people's lifestyle, doing total triage around telehealth and other mechanisms of managing patients remotely, managing chronic disease better, have more personalized care, and monitor patients more remotely. These are the kind of things that are going to change the way we make healthcare more affordable, but also enrich the experience of the patients. Let's go back 100 years. This is 1924. The futurist talking about the future of healthcare. And they're talking about remote diagnosis, remote consultations. They're talking about the radio doctor. Can you imagine 100 years ago, where TVs were hardly present? They're thinking about the future of health. We now call that telemedicine. And we've seen the escalation hundreds later because of the pandemic. In the first 4 months of the pandemic, we saw virtual visits go up by 8,000%. Here, Moffitt Cancer Centre, I think, shows 5,000% in their particular centre within 6 weeks. We've seen a deluge of telemedicine companies offering 24-hour access, immediacy of services, either consulting or messaging, etc. So now there's no excuse. You can access healthcare anywhere in the world almost on a 24-hour basis. So this is huge, of course, and patients now understand the concepts and the kind of reward, if you like, for having immediate care. Let's take telemedicine to its natural extreme, China. So I was in China a few years ago. I visited a couple of hospitals actually, and the numbers are just enormous. I remember seeing a clinic of 10,000 patients in the morning, for example, seeing a hospital of 10,000 beds. You can't imagine the size and scale. If you scale telemedicine, you come up with this. Ping An is an insurance company in China, and this was a year ago, before the pandemic. They had 300 million active users. They're performing 160,000 consultations per day. Can you imagine the size of that? And now it must be more, I imagine, not seeing more data recently, but they're really scaling up the use of telemedicine, remote monitoring, remote consulting. We may also move more remote. We want care in the community. This is an interesting concept, which I think will happen over the course of the next few years. It's designing almost primary care tools, boxes, remotely in the community. You could walk in, have an assessment remotely, measure your blood pressure, your pulse, your vitals, maybe your blood glucose, for example. There'll be a diagnosis there. You pop out next door, and there's a prescription waiting for you, just using a smart card, which would take your right medicines and you walk away. That makes it even more immediate. And Babylon Health in the UK have just brought out a whole chain of these kind of, I guess, medical units in America. So look, this is going to be amazing. It takes away some of the manpower. Remember, we had manpower issues going forward. We've got to repurpose people, we've got to reimagine, make the healthcare more smarter as we go forward. A year ago, I remember seeing this, and this man got so much criticism. A doctor in California appeared via video link to tell a patient who's going to die. Breaking bad news. He got so much criticism for doing this. Now, of course, it's routine. We are breaking bad news by telephone or by telemedicine. Now it's normal practice to be able to speak to a family remotely. Patients now seeing their loved ones die on a telemedicine platform. So a year ago, it was unacceptable. Now it's normal, the new normal. We've changed so much in our thought process. This is my clinic at the moment. I'm remote at home, seeing surgical patients. I have my laptop with electronic health record connected to my computer at work, so I can access all the data information of the patients. I have a telemedicine platform, attend anywhere, so patients queue up in my clinic or remotely. They are triaged prior to that. And then if I'm doing a ward round, I just take my beam. I don't need to leave my office. I can stay at home, do my ward rounds, see my patients. And I did this 5 years ago initially, and there was a bit of it's difficult because it's new. Now it's simple. All the patients were happy to be seen by a consultant, a specialist on his ward round. So I do ward rounds and I consult all remotely. One of my roles is to think about education. How do we bring the new generation into the kind of area of digital? How do we create this digital doctor or the connected doctor? Now, I was Associate Dean at Barts Medical School for 10 years. And Barts Medical School has been around for a long time. So Bartholomew's Hospital was founded in 1129. Can you imagine? Almost 900 years ago. And medical school has been around for 200 or 300 years. So it's an old-fashioned system, but it's changing and evolving. The curriculum hasn't been redesigned for years. The medical school curriculum is still 5 years long, or 6 years in some places. So my question to you is, why is it 5 or 6 years? Why can't we train doctors in 3.5, 4 years? If we need more doctors, as WHO tells us, we either need to employ more people or bring more people to medical school or increase the numbers. We have to do something. So maybe we can reimagine the curriculum and changing it appropriately. Also, it hasn't changed enough to be digital. This was coming. This digital transformation, like today during the pandemic, for me was predictable. We just sat on our laurels and didn't think about it. So what did I do? medical schools I work in, whether it's Harvard, whether it's Imperial, whether it's Queen Mary or Barts, whatever, I thought, let's repurpose this. So 6 years ago, I said, we need to change that. I brought in the Barts X course at our medical school. This was a course embedded into the curriculum for every medical student. They were taught by UI UX team, coders, developers, taught by faculty from the US. That's Daniel Kraft, John Noster from the US, of course, Daniel's from Singularity, and John Noster you know well as being a digital influencer globally. We brought the community together. So let's teach our students differently. They were taught by all these people, plus future technologies and innovation and entrepreneurship. They were designing business ideas. They were going away in groups of 4 or 5 and having mentorship from the tech industry to come back. And they came back. And we took them out. We took them out of the medical school. This is the kind of our Silicon Valley, if you like, of the UK in King's Cross. We took them to where Google were, where Facebook are, where all the tech companies are in King's Cross. We taught them about skills required to be not just a medical doctor, but also to be someone who understood the power of technology, to collaborate, if you like, in the future. And they're wonderful. We had this article in BMJ and showed the rise of medical entrepreneurs. We created the new leaders of tomorrow who understand the concept of business, of innovation, of entrepreneurship, as well as being good doctors. It's a mixture. Generation Y or Z are different to us. I trained like Angela's 100 hours a week for many years during my residency program as a consultant. Those are times of change. People want better work-life balance. They want to have portfolio careers. They want to change. Therefore, we have to adapt accordingly. And they're great. They create some great ideas, whether it's using VR technology for education, AI, neural loops, voice assistants. They're really thinking outside the box of how to improve their own experience as a medical student and in time a doctor. One of my passions, of course, is extended reality. I spent a few moments talking about this area. Extended reality is really interesting. It's really taken off in the last 9 months. On one side, you've got AR, augmented reality, where you can just oversee information onto a smart glass. On the other side, you've got virtual reality, which is where you're embedded into a headset. And in the middle, you've got something called mixed reality. I'll talk about some holograms avatar as well, which I've been working on. So this is kind of, this is kind of augmented reality. So you can see your glasses, and there's a huge plethora of companies that are trying to engage and work on this. And this was me back in 2014, which I'll share in a moment with you. So there's many glasses coming out. Google Glass came out in 2012-13. We have the Nreal glass. We have a number of glasses coming out now, which are more lighter, more sophisticated, better functional, etc. The world wasn't ready for Google Glass many years ago. It was just too early. It was far too forward thinking what it was. We're now going to stage now thinking, actually, smart glasses might be coming in. One thing that troubles me, and we'll come back to the smart glass moment, is of course conventional surgical training and education. And Angela's will share this, I'm sure. We've been teaching in the same way for a long time, in a big amphitheater, in the operating theater or the operating room, OR, as you say in America. We tend to call it operating theater. This was back in Harvard many years ago. The teaching here is not sufficient. You're teaching someone who's a distant away, who can't see a single thing. He's learning by a process of what I call osmosis and diffusion. There's no learning, no active learning. And we've assumed this was good enough for a long time. Let's fast forward. Here we are. This was at the, I think, Texas Heart Center. Can you imagine what anyone can see during that procedure? Nothing at all. And of course, we've taught our medical students in that way. We engage with them, they come to the operating theater. Very often they're ignored for 8 to 10 hours because it's difficult for people to get involved, you're busy with the operation, and sometimes they're on the back of the ward on their smartphones thinking, when can I leave this operating theater? We're not inspiring people because we haven't changed. We haven't challenged the dogma tradition of education. It's got to change. So one of the things I've been doing, so I've been a member of council at the Royal College of Surgeons of England from 6 years, and I left that about a year ago, but I had a great time there. And the RCS, of course, is about policy, it's about standards, just in the UK, but globally. And I took on the Global Health Programme. I ran the International Surgical Programme for training. What we did with that, we actually traveled widely to bring people from countries that were low and middle income countries to the UK for targeted training to ensure they could go back with skills for that country. So for example, one of the guys here from Kenya, he was looking after a population of 1 million people in rural Kenya as the only urologist, They lack some of the skills. We brought them to the UK, gave 2 years of training on cystoscopies and TURP, TURBTs, that kind of thing. We sent it back, and now I could repurpose and retrain people in that community. So I ran that for about 3 to 4 years, and we did well. We traveled extensively. I went to many countries, over 30 countries, all around the world, mainly aimed at low middle income countries or the developing world, if you like, and saying, look, how can we support, how can we collaborate, what's there to learn together? My work has also taken me to conflict zones. I've spent the last 6 years working in Gaza, a conflict zone, of course, bringing skills training to the surgeons there, running MDTs, running cancer surgeries, training lab skills, basic surgical skills. And this is kind of my challenge. How do we overcome the barriers of geopolitical problems? How do we overcome the hurdles that people face in the most difficult and desperate situations, whether it's Syria, whether it's other conflict areas around the world? So my work's always been, how do we bring learning, how do we bring healthcare differently to these difficult parts of the world to get to? We've done 5 years of work here, and we've got another 5 years to go, of course, to somehow bring equality to their healthcare system. I've messed around with different platforms, of course. This was me on Facebook in Bangladesh, training 10,000 surgeons in one go, because Facebook, of course, has over 2 billion active users per month around the world. A third of the world's population is stuck on Facebook, getting fake news as well as good knowledge base. I use Snapchat, can you believe it, to do a live operation to an audience. Can you imagine that? That pushed the extreme of what was possible. This was, and I did a Twitter operation, the first live Twitter operation ever, where we just did tweets across the whole day from our hospital. I also operated live on national TV. We did a 2-hour operation a couple of years ago. It was a laparoscopic right hemicolectomy for the public. And actually, it was really, I guess it was very disruptive. It's pushing the boundaries, but we decided to do it. And the response we got from the public was enormous. We were always very cagey about the OR. You know, we have to be very covered in mystique. Let's open, let's be transparent about this. And in fact, Operation Live was shortlisted for a BAFTA award, and yours truly went to the BAFTA awards a couple of years ago, which was an amazing experience for a surgeon who never thought he'd end up on the BAFTA award ceremony. The Snapchat operation, which I did, was covered by Time magazine, that reached 56 million people through social media. Simple hernia surgery based on social media. And you might think that's, why would you use Snapchat? Well, if you look at the average age of Snapchat user, it's between 18 and 25. 75% of users are that age. That's the same age as my medical students. That's how they engage. That's how they want to learn. So use those modalities that are free, open access to teach in different ways. 2014, let's go back. Here we did, this was 2014, where I did a live surgery using Google Glass. I got my students to configure the Google Glass on my head. We did a live operation, which we pushed out to the world. And on that day, I taught 14,000 people across the globe, just by using a simple, smart technology, wearable with my view, points of view approach, and it reached virtually the entire globe very quickly. So it showed you the power of connectivity. We created a whole platform of learning. Can you imagine, this is so relevant now. We did this 6 years ago. Now remote learning using wearable tech and creating a peer-to-peer learning platform back in 2014 called Glass Medics. I imagine to teach this man as well. This is John Scully. John Scully is the CEO of Apple, was CEO of Apple, and obviously, you know, worked with Steve Jobs at the early stages. And he's the guy who sacked Steve Jobs, of course, remember in the film. So I taught John Scully how to do remote surgery using wearable tech. This was us in Dubai together. He had a huge interest in mobile phones, and I was there using wearable tech, and we decided to do that. And I taught him suturing. So I'm really pleased I can teach a CEO of the $1 trillion company how to do basic suturing. AR is moving on with AR Core, the AR Kit in Android and iPhone respectively. We're seeing great use cases where there's something like this, which is Insight Heart. We're seeing real-time, almost smartphone usage of these technologies for education. And there's many of those, of course, out there already. Using augmented reality, my colleague in the UK, Nadine Harman, she actually has a company called Proximi, using AR remotely. In fact, during the pandemic, they did a live operation where one person was in the US, the patient was in the UK, and the surgeon, and they could actually interact together using AR platform, where the surgeon in America would point to things with his finger, show what to do, etc. during the procedure. So we're seeing now this kind of confluence of technologies and being connected, of course. The other passion I had was virtual reality as part of extended reality, and we've seen a plethora of headsets over the years. VR is not new. It's been around for at least 60 or 70 years. But what's changed is the power of the computer. This is where this kind of concept of the convergence of technology comes in. We have powerful computers, great displays, great graphic displays, so powerful devices getting smaller and smaller. Now VR is surviving. We're seeing now these untethered devices, whether it's Oculus, whether it's Pico, whether it's HTC, the untethered 6 degrees of freedom, which means you can move in any direction, motion tracking, eye tracking, hand tracking, everything. So now the experience is so much better. If you go back a few years, one of the teams in the US created Snow World. This was a game within virtual reality, a snow world, cold, with snowmen, with snowballs. And what they were showing was that children who could engage in the gamification VR, throwing snowballs at snowmen or whatever it is, it took away their pain, destructive therapy. They required less analgesia during, say, dressing changes after severe burns. So we're now seeing therapy, virtual therapy come in. Now we're seeing therapy for post-traumatic stress disorders, anxieties, pain relief. There's lots of papers out there in terms of this. Sinai, my friend Brennan Spiegel has been doing wonderful work in VR, and Diane Juris in Belgium, both doing lots of applied research in VR. On Comfort creates a new method for relieving patients' pain and anxiety before, during, and after medical procedures. This kind of revolutionized therapy combines clinical hypnotherapy and integrated therapeutic techniques through VR. You can see over 60,000 patients now have been recruited from these trials. So it's not small. We're seeing real world evidence of better outcomes in that. My own colleagues in the UK are now using VR for virtual lung rehabilitation. These are patients with COPD who go home, who can have everything measured within the VR headset and do exercises to improve their lung capacity or flow. We're now seeing women during pregnancy, labor, have VR rather than epidurals. We're seeing actually in randomized controlled trials that actually is a benefit to have VR therapy as attractive for pain during child labor. So it's amazing what we're doing. Patients, of course, are important. We're seeing a number of examples where we can experience what patient goes through. This is living through dementia. We can actually experience the world as a dementia patient, teaching us the empathy required to treat these people better over the next few years in the future. My old world of VR, I think Angela's mentioned it, we decided to take that Google Glass next stage forward. So 4 years ago, I used VR technology, 360 cameras of operating theatre to live operation globally.
This 360 camera rig allows immersion. People around the world using a low-cost technology, a simple VR headset, can actually immerse themselves in operating theatre around the world.
So we're seeing that simple, it's low-cost, high-tech solutions, right? And we literally did that 4 years ago, but showed that we could be effectively connecting with people and sharing information. Angela said we actually created a company, Medical Realities, and we were the first to really create a unique training platform in VR. What you see here is actually navigation through a VR interface. What does the learning look like? We spent years thinking about what's that experience and being in the OR, in virtual reality, and being there live to life. How do you interact with that environment and then actually learn? And then you go to simulation, practice, operation, surgical operation, and see how the knowledge base and learning. So you can start doing procedures in VR. We also have realized that doctors have not been able to do OSCE examinations. And so we create a whole a platform for OSCE training remotely, where now you can actually practice basic examination techniques, also procedures, etc., in VR, which will hopefully allow you in the kind of virtual world now to be able to be competent going forward, or at least bridge the gap between clinical work and this kind of immersive world that we live in, of course. We've seen people like Justin Berard, who's the CEO of Osso VR, who've just raised a lot of money from Kaiser Permanente Ventures to bring training in VR. And they've shown that actually it's far easier to train in virtual reality prior to the operating theatre, improves experience, and it's kind of all the procedures. So we've seen great utilities in that. My friends from PwC have shown the efficacy of VR learning. We've seen that basically people are more confident, they're faster than classroom training, more focused than e-learners, and more emotionally connected to the content than classroom. We've seen less time in the classroom and less timely learning. So we've seen the advantages. The amazing report actually a few years ago suggested that we retain 80% more information in VR than we do with any other platform. So there's the great ideas there. When I talk about mixed reality, we've seen the HoloLens coming out, also the Magic Leap, in the last couple of years. This is the HoloLens 2 version now, which is an amazing technique, an amazing platform. And we're seeing people like Apoklar now showcasing you can actually relay information from MRI CTs over a patient. So for operating theatre, at some point, this will help planning an operation, during the operation maybe, making it more precise and more accurate. And my friends from Japan, this is Maki Sugimoto, and see from HoloEyes, overlaying real-time information in the abdomen. This is the liver surgery being carried out. Imagine as this gets better and better, we can show important structures to avoid or show the tumor and where it should be resected, for example. So with this is the area we're going to be heading towards. Now you may think that's kind of far-fetched. Already, companies now have got FDA approval for these kind of augmented reality surgical planning platforms. One of the things we've had at our medical school, they've had no face-to-face teaching for the last few months. So I thought, you know what, this was just about 2 weeks ago. Let's take them on a ward round virtually. Let's do that with a mixed reality device. So we had them in the lecture theatre, all social distance, 70 of them when there's usually 400 of them. And then we taught them using reality. Anastomosis. And so what's happened is that sometimes with this staple line by the pancreas, you get leaking of fluid, the pancreatic fluid, and that's what you're seeing on the drain. And the drain helps evacuate it without accumulating in the. So that was me on the ward, seeing patients, doing my ward round. They could see what I was seeing. I had images coming up through AR, so I could have the x-rays images, the blood results. The moderator in the lecture theatre was then connecting with them, and we could have great conversation. It's actually, and they loved it. They really had a great effect because they weren't getting face-to-face. So this is going to change, I think, the way we teach going forward. I've also thought about how do we create avatars and holograms. I travel a lot and it's very expensive, time consuming, probably not efficient use of my time, and probably doesn't really encourage the climate to get better. So, we will have responsibility, of course. So I've been thinking about this for a while, and my dream was always to be, how do I transport myself, like in Star Trek, like Spock or Captain Kirk, of course. And we've been playing around with a few things. So this is me doing an operation a couple of years ago, using my avatar in mixed reality. I thought, can I connect with surgeons from India in Mumbai, me in London, and someone in America, for example, 3 time zones in 3 different continents. Hi, everybody. Hi, Shafi. So the HoloLens itself really allows us to reshape the way we connect people, we communicate with people, and also to be used in teaching and training. Initially, when you put the HoloLens on, it feels a bit strange, but actually within a few minutes, it becomes quite normal. You feel as though you're just discussing cases with people in the same room, for example, like we do in normal hospital practice.
We can come in and actually look at this content in full 3D. And obviously when you're working in this case, the medical field, having a full 3D understanding of a situation, for example, is really much more powerful.
That was a few years ago. What about, that was avatars, blue polygonal images, not real. What about holograms? This was us using 5G technology and with a company called Double Me, using my hologram.
Shafi, have a look at this.
Yeah, let me have a look over your shoulder. Oh yeah, I see what's going on there. I think I can give some advice, Carl.
Imagine that in the future. During the pandemic, this is another work we do. We thought, how do we do something even better using mixed reality devices? We did this over the COVID pandemic at the beginning, actually.
Hey, Dr. Ahmed, good to see you again.
Hey, Harrison, so good to see you. Where are you?
I'm in New York. How about you?
I'm in London, so good to see you. I think we've got Ian here as well, haven't we? Hi, Ian.
Hey guys, I'm in downtown Atlanta right now. Thanks for joining me. I forgot my magic leap, but I've got my phone handy, so joining you through here.
Thanks for joining us. Should we have a look at some images to help us in this regard? Let's try. I'm just going to pull up an image of the virus itself, just to show you what it looks like.
That's more clearer. You've got better avatar. There's kind of speech movement. The arms are moving. It gets more realistic. We're now seeing mixed reality being used in smart ambulances. This is in Italy with the Vodafone team. So now with mixed reality, they can take all the measurements, relay information back into the host hospital like I used earlier through a ward-round training. So now we're going to be seeing this smart technology using mixed reality coming into the smart ambulances and remote areas. One of the areas, of course, we're thinking about is remoteness. Now we do remote teleconsults, but what about managing patients in that sense? So one of the things that's been obviously during the pandemic is the management of diabetics and also those with chronic obstructive airways disease or asthma. These are chronic conditions were managed between secondary and primary care. Now it's all in the community. We're now changing the way we manage those long-term patients at long last. We can try and empower them more at home. That requires sensors and wearables and measurements and data-driven healthcare. What we're seeing here, of course, a number of new parameters, with the Apple 4 watch, measuring oxygen saturation and doing ECGs now. We're seeing we're seeing these kind of nanobots in the stomach. We're seeing skin. This is Profusa putting a small kind of chemical underneath the skin, which will measure saturation of oxygen, for example. And skin itself could become a monitor and sensor. So we're now looking and really delving into this new way of thinking about how we have wearable sensors. But realistically, we're now seeing bodysuits, of course, with all sorts of parameters being measured from the body. We've seen this is a live core that you will know from the team at Cardia, creating ECG measuring atrial fibrillation. We've seen the glucose patches on the deltoid, the Libra device setting continuous monitoring of glucose, and now we're seeing the artificial pancreas coming in, getting FDA approval and getting measurements going forward. So we're seeing a real plethora of the technologies coming in. As we go forward, of course, genetic medicine's coming in much more and more because it became more cheaper. We've seen during the pandemic with the mRNA used for the vaccines produced. And of course, it's crucial for us. What's important is the cost per genome sequencing is coming down. It was $1,000 about a year ago. It'll come down to $100 and $10. And then we'll have all this data from patients to think about how we use that in the future. We know that CRISPR gene, for example, can actually halt progression of some breast cancers possibly. We're also seeing the other side of technology innovation. We saw the gene-edited twins created by China that changed the way forever that we're going to look at some of these ideas because they pushed the ethics towards across the boundary and they took chances. Actually, were we ready for some of those questions around ethics and the use of these kind of technologies? And that's something that we can discuss afterwards. We're now seeing companies think about longevity. How do we live longer? How do we make our health longer? A number of companies spending billions of dollars a year trying to repurpose and imagine how we can extend our lives or indeed improve our lives. It'd be great in the future if we all have 80 years of life that was well and we're healthy rather than 100 years where we had chronic diseases. We've got to think about what does health look like in terms of the future. Of course, no talk will be finished without having a whole session on AI. I'll run things very quickly with you. AI in healthcare is going to be the single most important change going forward. It's going to be the back end of healthcare. It's promised a lot before, hasn't delivered. Now we're seeing more traction with good use cases, whether it's diagnostics, whether it's drug discovery, whether it's chatbots and these kind of medical devices. And of course, we'll talk about AI surgery in a moment or two. There's no shortage of AI companies. There's a plethora of AI companies going out doing all sorts of things, whether it's to do with early detection or triage, diagnosis, treatment management, or monitoring outcome, looking at different data inputs, either natural language inputs, patient data, biometric data, or operational data from providers, creating an operational database, if you like, going forward. So this is the landscape of AI that we're dealing with. It has use cases in dermatology, in eyes. The DeepMind team, the Google DeepMind team, worked with Moorfields in London to diagnose retinopathy, early eye disease, using AI algorithms. They've just now looked at protein structure, which is amazing. If you look at the current work they've just done, they've just unraveled protein folding, which is going to be essential to understand how proteins are synthesized in the cells. Radiology, we've seen huge impact with radiology companies like Zebra, who are now giving you AI interfaces. ChestNet was the first one from Stanford, who compared images between radiologists, and it found that AI was good as two radiologists on a single chest X-ray diagnosing pneumonia. So we're seeing imaging being used widely. During the pandemic, NHSX has actually contributed a lot of money towards AI. It's invested heavily. And we actually made all the X-rays and chest CTs open access to everyone who wanted to use it for diagnostic purposes. We saw the first use in Bolton showcasing actually we can predict the outcome of COVID with the CT scan or chest X-rays. My own specialty of colorectal surgery, of course, is important, and gastroenterology. Here we are. This is the device by Medtronic, GI Genius, and we've seen now how you can detect polyps in the colon that you couldn't see before. So in the future, maybe we have to determine which polyps are good, bad, which one we should take out early, which can be left alone in the future, and hopefully avoiding some of the issues going forward. And this can be done remotely in the future, of course. Diagnostics is very important. We start doing ultrasounds, etc., using AI interfaces. We've seen the butterfly team obviously use their scanning machine widely, but what would be important is once that's AI driven, so anybody can use that scanning machine on any patient around the world, democratizing healthcare and getting an accurate diagnosis. So we will see more and more diagnostics being disrupted using AI technology. We mentioned earlier the whole doctor-patient relationship being transformed with telemedicine. Of course, now we're seeing AI chatbots coming in. And kind of your symptom checkers, whether it's Ada, whether it's Babylon, whether it's Sensely, there's many others out there all using these interfaces. But what about if we go further forward and recreate the doctor-patient interaction using AI, voice technology, all kinds of technologies? This is Babylon's version of what it could look like.
Hi Louise, my name's Dr. Kultag Archer. Nice to meet you.
Hi, nice to meet you too.
So I can see you've completed our AI assessment, and from this, can I confirm that you've been having dizziness for a few months now with some hearing loss and also some ringing in your ears?
Yeah, that's right.
Okay, you look quite comfortable at the moment, so does the dizziness come and go?
Yeah, I don't have it at the moment.
Okay, and when you do get the dizziness, how long do the symptoms last?
A few hours at a time, I'd say, probably, yeah.
Okay. And does changing the position of your head bring on the dizziness? Sorry, what I mean to say is, do you get dizzy, for example, when you turn your head to look to one side?
Well, see how the interaction is playing out. Real-time engagement, looking at facial expressions using AI, real-time monitoring of the conversation, and so the diagnosis is becoming more apparent with a higher percentage chance of being right. And then the natural voice language processing, as well as voice to text. You can imagine how easy it would be to consult. We're now using, of course, smart devices and Alexa or kind of Google Home or others, and it's becoming more common. What about if that became your control mechanism?
Hi Alexa, I want to speak to Babylon.
Hello Louise, how can I help you?
Well, I've been feeling a bit dizzy recently.
I'm sorry to hear that. Can you tell me a bit more? Do you feel like the room is spinning, or are you feeling faint?
Yeah, sometimes it feels like the room's spinning.
And have you noticed any hearing loss?
Yeah, I have actually.
Do you have a ringing, buzzing, or humming sound in one or both ears?
Yeah, both ears. It's horrible.
Do you have any pain in your ears?
No.
Have you had a fever?
No, none.
Have you noticed any discharge coming out of your ears?
No.
Looking at your user graph, I can see you had glandular fever a few months ago.
Oh yeah, that was awful.
For how long have you been unwell with these symptoms now?
A couple of months.
Finally, have you noticed that your ears are feeling full or blocked?
Yes, actually.
I think I might know what's been causing your symptoms. It is most likely to be Meniere's disease, a condition of the inner ear that can affect balance and hearing. It could also be labyrinthitis, an infection of the nerve in the ear. Meniere's disease needs a specialist opinion and might be helped with some medicine to reduce the dizziness, so I'd recommend talking to one of our GPs.
Sure, sounds good.
Dr. Garcha is available straight away, and according to your calendar, so are you. Would you like me to book your appointment?
Yes, please.
So you see the interaction there could be a model of the future. Voice is really powerful. Voice technology is coming in. This is beyond verbal. A company that used your vocal biomarkers. You could talk to an app every day, for example. And if you had cardiac disease before, it would predict the onset of cardiac failure 2 weeks before it arises. So therefore you can manage outside the hospital, prevent admission, and of course, potential mortality and further morbidity. So the vocal biomarkers, voice technology is huge. This is my model of the future of health. The first time you see a doctor, it won't be a doctor, it'll be an AI-powered chatbot. As you see the top middle, you're asking questions. This is a patient with hemoptysis, for example. So you talk about your vomiting blood, your coughing blood, you take through questions, it tell you, you know what, you need an X-ray. Automatically, an X-ray is configured for you, and a chest CT scan, you go in, and that is diagnosed by an AI straight away on your smartphone. You then go for a biopsy, and that biopsy can be done remotely. This is actually Johnson & Johnson's new technology coming out. We can actually now use AI-driven kind of guided pathway, take a biopsy from your lungs. So navigation tools, be much more precise, etc. And of course, you have surgery, and that can be done remotely using a robot, using 5G technology. So this is the kind of the future that I'm kind of thinking about as we go forward. Last few slides on surgery. This is my own specialty, of course. Digital surgery is coming in as a new concept. We've had digital health for many years now, digital surgery, a new terminology. With robots, enhanced visualization, advanced instrumentation, connected, and also using analytics from data to drive much better care, to look at your outcomes in a different way compared to the kind of the, I guess, analog version of looking at outcomes at the moment. Robots coming in, many robots are coming in now. In 2020, there's an explosion of robots, smaller, more discreet, more powerful, if you like. And this is a robot for plastic surgery that's coming out, it's tiny. And you can see how tiny these things are going forward. What about doing transatlantic operation? This is back in the year 2000, where they did a live operation going from UK all the way, so from France to the US. So what they were showing was you could do live surgery using the old-fashioned lines. This was a cholecystectomy being done remotely from France to America. But this was 20 years ago. What about now? Well, 5G is coming. 5G represents much higher bandwidth, low latency of 0.1 millisecond, which is imperceptible to humankind. This was in China, Eastern Province, doing remote operations using 5G technology. So you can imagine 5G being the connected piece now. And I call it the covalent bond, bringing the Internet of Things together, or the Internet of Medical Things, to allow us to use these technologies going forward. We look at autonomous vehicles, and I've got a Tesla, and it is just amazing. Okay, we're learning how to be autonomous, what the rules are, and ethics around being completely autonomous. What about surgery? Here we are, this is a few years ago, where a robot surgeon was performing an anastomosis, a joint between two bits of bone together. So we may be assisted, supported in the future with robots, automation, etc. The last few slides around this human connect between robots and humans. What's that connection look like going forward? We've seen the brain-computer interface being described, the BCI, whether it's Tesla's or, Elon Musk's Neuralink or others, connecting now the brain. And hopefully in the future, we'll see some kind of link that's going to be a BCI. And many companies out there working on this space. This is my friend, Nigel Ackroyd, who died recently, about a month ago, of esophageal cancer. But he, if you ever get to listen to his story, look at his TEDx story. His TED Talk is amazing, inspirational. When he lost his arm, he was one of the first men in the world person to get this futuristic bionic arm. That's him. Wow, shake my hand.
Where are you?
So he was controlling that through muscle movements in his upper arm. So it already is a BCI actually in purpose. And in the future, we'll be looking at digital humans. People will now look like us, who talk like us more.
Hi, I'm Roman, a digital human brought to life by soul machines. With me, you can experience AI like never before because I learn and react emotionally like humans do.
Can you imagine that being a doctor in the future, emotionally kind of aware, with empathy maybe, who knows, I'm not sure we're going towards. The last few slides about the real future. You know, we're going to be going extraterrestrial at some stage, and Mars is going to be on the horizon. We're seeing a space race come back. We've seen Elon Musk's vision with SpaceX and others, Virgin Branson, and also, of course, the Amazon's Jeff Bezos with his Blue Amazon. So we're seeing different kind of companies coming in, think about space. What that allows us to do is think about the Earth being remote, using different technologies to get to space actually is beneficial here. Of course, 3D printing is coming. We've seen people now 3D print devices or casts for orthopedics, bones for injuries, etc., planning operations, and the cost has come down considerably. It's now affordable to do 3D printing. But of course, they sent 3D printed space a few years ago, made a space team, and actually they built one of the astronauts while in space broke his finger, so they sent a far up towards the space station. He 3D printed his own splint and carried on working. Can you imagine that? This is the kind of way we're thinking about how we work in the future. We're now seeing 3D printed kidney. This is Dr. Tala's work, trying to create a nephron, 3D printed heart from Israel, and now we're looking at skin, seeing how can we 3D print skin, take away that's kind of the pressures around having skin regeneration or skin grafts for people with burns, etc. So we're seeing great methodology. But of course, this is interesting, drone technology. We're now seeing, perhaps this was a drone, of course, taking a transplant in America from one place to the hospital. We transplanted in quick time. We did it very quickly. In the future, we might see drones flying over remote areas, for example, who can do pitch down, support, get first aid out to people straight away, because drones are going to be fast, quick, and hopefully much faster than human beings going to remote areas. This is obviously drive-by space. We can imagine this could happen in rural parts of the world that we live in, where the care is not as easy to get to. So these are kind of things to want in the future. The other thing, of course, is we're going to all become Iron Man. This is Richard Browning from Gravity, it's his company. This is remote in the UK. So if you had to get to a mountain rescue, for example, it takes half an hour, he could do that in about 30 seconds, getting care really quickly to people who need it, powered by his own arms, which has got some kind of powered devices and flying through. So you could get there very quickly, of course. But actually, this is...
Hi, Dorian. So nice to meet you. So I'm Dr. Dewberry, and I'm here to take the neurology exam. I just need you to relax and just follow my instructions, okay? The first thing I need you to do is to keep looking directly at my eyes and then follow my instructions. So this is the pen light, and I'm going to shine it into your eyes now. Okay, keep looking at me. That's great. That's right. Good. Now I'm going to shine the light in the other eye, but keep just looking directly at my eyes. Right? Okay? Wonderful.
So I've taken a journey. I hope you've enjoyed that. And I'll leave you with the last quote by William Gibson, who's an American-Canadian author who coined the term cyberspace. He says that the future is already here. It's just not evenly distributed yet. Thank you so much. I hope you enjoyed that. And I hope now we can have another lovely Q&A, and I'll be happy to answer any questions.
Thank you very much, Professor Ahmed, for the fascinating presentation. Just excellent. So let's give Professor Ahmed a virtual round of applauses. And now we will proceed with the Q&A. Although we won't have the time to go through all the questions, we will try our best to answer most of them. So we have a question from an anonymous, and I said, what have been the public and government response to some of these highly technical innovations and expensive innovations?
So look, I think we're in a different place. If you'd asked me a year ago, I'd say there was difficulty for governments and regulatory bodies to accept this. But this 9 months has changed everything, Angeles. People now being more innovative. We've seen billions spent on innovation during the pandemic. We now know that has an advantage in the short term, but maybe the long term. And people are now more understanding that we need to innovate and we need to make changes. So I'd say we're in a different place. I think it's a kind of, it's like a springboard, as I said before now, for us to keep that door open and keep innovating and bring those stakeholders together with us. So whether it's government bodies, whether it's industry partners, whether it's healthcare systems, it's collaboration now, think of those ideas. So I think of course, as you implement change, costs come down. People often think about the short term, and healthcare is very much short term. What do I get next month or next year? Actually, we're talking about here's long term now. Long term goals. How do you manage population of 7.58 billion people? How do you manage increasing population, more chronic diseases? So you've got to think about the long term, which requires investment. So the way you do that, of course, is that you have smarter solutions, smarter ways of working to reduce the cost, keep patients at home, take the expense out of secondary care, and use that maybe to innovate further. So I think it's the whole mindset that needs to be changed, of course, and we're seeing that already.
Wonderful. We have a question, and I think this is related to the medical student. And the question is, will attendance be tracked for credit with the International Student Program Office?
Sorry?
Can you hear me?
I can hear you. I didn't get the question. What's that?
So the question is, will the attendance be tracked for credit with the International Student Program Association? And I think this is the attendance to that class that you were remotely with the student. I assume that was the question.
Actually, if I could add a second, it's something for UC San Diego, and so you don't have to answer that. I answered it in the chat.
Oh, okay. Thank you. Thank you. Then we have a question and a comment from Nora. And thank you for this inspiring and eye-opening talk, Dr. Ahmed. I have a quick question. In your experience, have you noticed a generational gap in patients' openness to artificial intelligence technology with their care? A few years ago, a few of my peers and I were trying to develop an at-home smart device to aid and eventually possibly replace caregivers treating Alzheimer's disease patients. During our prototype testing, we found that our elderly patients were not very receptive to the technology and were scared easily by it. In your opinion, do you think that these technologies will be more accepted in the future, given that the younger generation has been exposed to technology from a younger age?
Yes, so I think yes. I think the younger generation, of course, digital natives, they understand this better, their conversation is better, and I think they'll be more receptive to these ideas. Moreover, I think it's more about re-engineering society, social re-engineering, to accept different methods of healthcare, different ways of working, which is the responsibility of governments and all of us as citizens to ensure that we engage with this. There's also the digital divide, the vulnerable groups who don't have access to, say, the internet, or who may not be well versed in terms of using computers or digital technologies. So you have to allow for that. You have to create a system where it's fair for both, that one group isn't disadvantaged. So it's going to be parallel systems where hopefully in the course of time, the disadvantage will be less and less. Of course, they'll be more empowered with their families supporting them, etc. We're seeing now elderly patients being supported by the family to have telemedicine consults, they beam in and they help support them. So I think it's a mixture. Undoubtedly, the younger generation, of course, is going to be more savvy going forward, and they're the ones using these kind of technologies more than other people. But I think one has to be very careful. And this is why, although technology is great, innovation, it's not about replacing things, it's supporting, it's augmenting our practices. And replacing is the wrong word to use. I'll never use that. It's how do we augment our practices better, take away some of the automation that we need to do, make almost in some ways ourselves more human. So we spend more time doing things that we were trained for, spending time with the patients and letting everything else be managed in different ways. I think I look at the future as being much more measurable in that sense. But I think we just have to be very careful that we don't disadvantage people and make sure we deal with that as we go along.
We have another question from Anish, and that is, when digital health becomes autonomous, how would accountability be ensured?
Yeah, it's a really good question. And this is ongoing. I think we will discuss this going forward. But I asked the question, Anish, what about banking? What about all the other things we do? Where's the accountability for those things? So people have thought about these ideas already. Look at Tesla, the car industry, autonomous cars. When they have accidents, and there's been a couple of deaths, I think, not many, what is accountability like there? Is the software? Is it the car? Is it Tesla? Is it Elon Musk? Who is it? So we're learning a lot from other industries because they've achieved autonomy much faster than we have because it's less risky for them. So I think we'll take that learning and bring it forward. We have to be fairly open and transparent about what we do. Understand there's there's risk attached to it, but mitigate it as far as possible. But it's about having those conversations, Niche, having the conversations, being bold enough to actually what are those risks we need to deal with? How do we manage them and being sensible? And that's where we need to be heading towards. And I haven't seen that from many governments, but I'm assuming over the next few years, we'll see a kind of way of having that accountability more measured, being sensitive about where that lies.
We have another kind of similar from Lam Castrati. I apologize if I'm not pronouncing the names well. What would be the ethical issue if mistakes happen during surgical intervention with robots, if the problem is not caused by the doctor, but by the software of the robot?
Really good question. Let me take another analogy. Say you're doing, I don't know, a anterior resection. This is a rectal cancer you're taking out, and you're doing a joint with staplers. What if that stapler fails? For example, it does. We've seen it before, right? Who do you blame? Who's accountable? All right. This is taken to the next extreme, of course. This is another medical device as such. So it's not going to be doing the operation. We'll support, augment our practices. Yeah. But I think before we do that, I think we're intelligent enough to put in safety measures in place to ensure that we mitigate it. If there are, we have a proper understanding. And we'll have more data analytics to analyze what went wrong. At the moment, if things go wrong, we have no data analytics. We just do a kind of, we look at it afterwards, we think what could have been done better. Imagine when you have a data-enriched system where actually you can go back to actually, where did we go wrong? Where could we have improved, etc. So I think it's a bit of both. I think we as a medical fraternity will manage that risk, will be sensible. We won't be cavalier, hopefully, and we'll make those adjustments as we go forward.
Another question from Tom Agoston. You mentioned some large companies like Pfizer and Johnson & Johnson. Are these promising med technologies coming from large companies or smaller companies or academic? Which are more innovative?
Yeah, really good question. So look, I think, so there's a mixture here. The ecosystem of innovation is quite big. So look, I run 2 health conferences, as you know. Last 2 days, we ran the Giant Health event. We had over 1,000 small startups competing for our prize, okay? When I do the Webbit, we have over 1,000 startups competing for a prize in Spain. And there's a lot of great small companies out there. What happens? There's an ecosystem. They go through accelerators, or they go through incubators, they may get investment. Most will fail, of course. And some of the companies offer that. So these large companies like J&J have their own innovation labs. So the J&J labs, for example, Pfizer have their own. They nurture some talent because they want to have access to all these people who are doing great things. Ultimately, they'll get bigger. So J&J rely on people like us, small companies, to come with ideas. They either buy them out or they support them. At the same time, they spend money on their own teams innovating. So it's a mixture of areas that come from. And look at digital surgery, a company based in the UK. 2 surgeons created a company called Touch Surgery, which became digital surgery, creating training tools and now AI interfaces. They were just bought out by Medtronic for hundreds of millions of dollars. Okay, so their idea was unique. It's great. So we're seeing a great collaborative work now where people are encouraged to innovate, to think differently. So to your question, really, Tom, it's a mixture. Of course, large corporates will innovate and they'll have their own system in place. They also want people to come to them with ideas, support them going through. There's the incubators, accelerators, etc. to support you. So I think it's quite a rich network of people now. And
another question. Oh, sorry.
Yes, a lot of academic institutions, of course, amazing. They come with right ideas. Look at Look at this kind of whole research around these Pfizer or BioNTech, whatever. It's required Oxford University to nurture that, to create the clinical trials for them to come in quickly to create a vaccine. So, the word is collaboration going forward.
Another question from Anne Granas from Norway. Thank you for your excellent talk. How do you integrate the patient perspectives in digital health technology? For instance, in empowering them to add mobile health data to medical records, or to adhere to medical treatment and adjust doses, etc.
Yeah, so one of the things I think we've failed on is having the patient voice enough in innovating. Yesterday, we actually had our event, and we dedicated one of the sessions to a friend of ours called Michael Serres. He ran a company he was a patient who had Crohn's disease, ended up having small bowel transplantation, and lived with that for many years, and who died earlier this year. But he actually created his own platform, his own, device to stop stomas from leaking. Stomas are horrible things to have, with colostomies and ileostomies. And the bags, he created a special device himself using his knowledge and experience of having stoma. So we need to encourage more patients to come into that field. The other thing that he mentioned, I'll share this, he said that when we have startups or these companies going forward, we have a CEO, a chief operating officer, maybe a chief medical officer, et cetera, We never have a chief patient officer. And he says it's vital to have some kind of understanding of patients and their perspectives in health. Also, I think we've taken them for granted. We've actually been very hierarchical. In the last 9 months, who would have thought patients would be okay with digital technologies, with telemedicine platforms, remoteness, managing their medication remotely? We haven't given them enough, I guess, respect in that sense. We've been very, very paternalistic in our care. Now we're seeing a change where actually patients are demanding immediate care, demanding care at their convenience. So actually, I think it's been a good thing in that sense. So I think as we go forward, the patient voice needs to be heard, of course. They'll be more involved in those conversations, if that helps you, Anne, from that question.
Halita has a question. Synthetic mRNA and machine learning. Where do we see the future going?
Really good question. Well, great. Well, so look, if you look at synthetic mRNA, of course, we've seen how it's being used now, how mRNA is translated for vaccines. And I did a whole PhD on microarrays back in 2000. I actually worked near Princeton with Bristol Myers Squibbs in the US. And I remember back in 2000 when the genome had just been unraveled for the first time at a cost of how many hundreds of millions, and to see where we are today using the mRNA technology for vaccines. But I think in terms of the machine learning, absolutely. So AI machine learning is almost propelling drug delivery and drug discovery at pace, analyzing structures like you just seen with Google DeepMind, the protein folds. We see now people like Benevolent AI creating rapid drug discovery and clinical trials. So actually deep machine learning isn't just about the synthetic mRNA, is that whole process of biological derivation, identification, then analysis, creating those molecules, clinical trials, looking at them with the experience of machine learning. So it'll be completely embedded is that whole pharmacogenomic program.
Sharon has another question. Using augmented reality for surgical training, does it offer any tactile sensations?
Yeah, so one of the things people always ask about is that tactile feedback. It's the kind of the haptic gloves or haptic feedback, whatever. And I've been working on that for the last 5 years. So VR technology now is offering some haptic devices. We're getting things just in terms of some of the movements are just very generic. We can feel vibration, etc. In the VR headsets now with Facebook and others, Oculus, you get much more experience now in terms of vibration sense. People are now bringing out gloves with sensors so they can actually start feeling a little bit further. We're still not there yet. Still, 3 or 4 years ago, we were talking about this, and we still haven't got to that stage where we can use them routinely. But there are companies out there rapidly developing, deploying some of these ideas. So watch this space. The other question, does it make a big difference? So if you look at some of the papers, actually haptic feedback doesn't make as much difference as you might think it does. If it's procedural based and you're going through a system, say doing a procedure, haptic feedback isn't as important actually as you think it might be in that simulation training. It's important in real life, of course. But I expect at some point we'll have some devices that will replicate some of the sensations we have to allow that more of a simulation to take place. But I reckon, I keep saying it's every 2 years. So I'll say another 2 years. At some point we'll get there.
Anish has another question. Mobile phones are a great resources to enable digital access health to almost every corner of the world. However, many rural communities still don't have access to proper internet, let alone 5G. So what solutions are being implemented to improve the same?
So you're absolutely right. Obviously, that depends on having technology. Do you need 5G? Maybe not. You certainly need at least a 3G, maybe connection, whatever it is. So what people do, most of the world has reasonable connectivity at the moment. There's huge pockets there of deprivation. So let's look at what people are doing. Look at Starlink. So Elon Musk is sending a whole bunch of satellites around the globe. Already you can see them if you take pictures, and they are trying to bring connectivity to parts of the world. Google, with their Loom project, will bring balloons. Remember those large balloons into the atmosphere? And they can actually circle and give internet connectivity. And that's been used in some parts already. In fact, I think it was used during the Haiti disaster recently to provide that connectivity in that sense. We saw Facebook a while ago producing those drones, and actually those drones it failed. They did 2 sessions. It seemed to have walked away, but they had a drone flying at 50 or 34,000 feet with a huge wingspan giving connectivity. So we're seeing more and more of these global companies saying, how do we connect people better? And also remember, the mobile networks are much more wider now. 5G is better. You can have many more people on 5G networks than 4G. They take less space. You can expand much heavily. And actually, of course, that's going to be interesting. And then, of course, some people already talk about 6G before we had 5G. So I agree with Anish. I think there is a problem there. But I think there are solutions. And the governments themselves need to take accountability. If they want to connect people properly, they need to invest in the technologies to reach rural communities. It's just a question of time, I think, before we have reasonable connectivity for all parts of the globe.
Tom Austin wants to know which countries has the best policy for supporting innovation in healthcare. Not politics, but a lightning policy.
Really good question. So in my experience, I think the Middle East is great, whether it's Dubai or whether it's Abu Dhabi, amazing. The people there they want change to come in quickly. They really had, for example, the Hyperloop out there for a number of years, and they're trying to support Hyperloop going in. And the Dubai Futures Foundation supports global innovation coming quickly at pace to change. Abu Dhabi government, for example, they have a Hub 71, which is like an innovation hub in the World Trade Center in Abu Dhabi, invested to the tune of about $4 billion from the state sovereign fund, Mubadala. And what they've done there, so if you have a healthcare system coming in or healthcare innovation, we will open the regulations, make it easy for you to come in, to develop your ideas, and to use it on our population. So they changed the rules, and actually, if you use it on our population as in healthcare, you have like a 1 to 3 months window where you would have no liability, because we want you to test out and support us in the right way. The other parts like Singapore, I've done some work in Singapore, and actually they're great. They innovate, they want to go into practice, and they're quite forward thinking. But all countries generally have innovation pockets which are great. Yeah, if you go to China, you can see amazing innovation in some hospitals you can't imagine exist. Yeah, so actually it's about parts of the population, but the governments I think are great are the Middle East. We'll talk about, of course, Southeast Asia. And of course, the other one, look at Rwanda. Rwanda a while ago were in the midst of a civil war. Now with their leader, they're actually innovating. Babylon are there already with their digital medicine platform. He's bringing technology in, even being a poor country, he's investing heavily in infrastructure or digital. So these are great examples of countries that you wouldn't expect are doing really well.
Naima Ali Khan, Dr. Shafi, do healthcare systems have capacity to embrace these technologies? In the UK, national and local health and social care are many steps behind.
That's true. I think we're getting better in the UK. I think we've seen that in the last 9 months. We've got lots of organizations like NHS Digital, NHSX, NHS, the academic health science centers, the global digital exemplars in the hospitals. So we're seeing much more interest, and we are seeing more innovation. For example, the AI team at NHSX, they have an AI hub now, open source all the images, X-rays I mentioned before, investing heavily into AI companies coming in and supporting them through the translation into practice. So I think we're getting better. There's no question. And I think healthcare systems now are actually understanding it. And if they don't do it, they'll be left behind. I think we get to a stage where they realize, unless they adapt and change, the healthcare system won't be fit for purpose. And this 9 months has helped accelerate that kind of understanding.
And the last question, because it's 9:30 in London, and by David Gomez Ladron. Thanks for the great talk. How do you think technology can be integrated in contact-dependent specialties like physical therapy?
Yeah, really good question. So physical therapy is a really important one. And it's like, I've seen examples where you can do physical therapy in the VR. So rehabilitation, for example, say you've had an orthopedic hip or knee operation. At the moment, it's, you see a physiotherapist or gets physical therapy or whatever, or if you're recovering from a stroke or neurorehabilitation, actually a lot of that could be done in, say, virtual reality as an example. We're seeing that now. We can experience, you can go through movements, you can be assessed remotely, etc. So actually thinking in different ways of empowering the patient more and more is being useful. So I do see physical therapy changing enormously with some of these technologies, whether it's VR, AR, whatever it is, we are seeing that change.
Thank you very much, Professor Ahmed, for your time and excellent presentation. I also want to thank the San Diego chapter of the Fulbright Association and the University of California, San Diego Division of Global Education, especially to David Gianni and Adam Weaver for making this webinar possible. And finally, thank you to you all for attending the webinar. We will send you a link with the recording and a brief survey for your feedback in a couple of days. Be safe, wear a mask, and thanks for joining us. Bye-bye. Adios.